Okay. So the time has come to start the webinar. And today's topic is a very unique topic, but still a very common topic which you come across in your pain practice. Let's deal with peripheral neuropathy, right? Peripheral neuropathy cases are on the rise. Causes could be anything, but in chronic pain, neuropathic pain is a very important component which we should excel in managing. So, to deal with this topic, we have our resource person, Dr. Mohammad Zunaid. Dr. Mohammad Zunaid is an MBBS, BCS, FCPS, and MD, IASP, and WFSA Fellow, Clinical Pain Management, Siraj Hospital, Mahidol University, Bangkok, Thailand. He was a research fellow at Imperial College London, UK. He has done quite many courses, a few of them being postgraduate certified course from AIMS New Delhi and Ramaya Advanced Learning Center, Bangalore. He was the IASP award winner in the year 2024, WFSA mentorship program from Kingston Hospital, NHS UK. He's a pain consultant at Lab 8 Cancer and Super Specialty Hospital, Lab 8 Diagnostics and High Care Hospital. Member IASP membership and chapter committee, and member Presidential Task Force of IASP. So quite a lot of accolades against his name. I'd like to welcome you, Dr. Zunaid, and to kindly start with your topic for today.
Thank you very much, Dr. Javed, for your nice introduction. I think, am I visible? Please, would you please
You're
make,
not visible. You're not
yeah,
visible. Yeah.
would you please make it my screen share? Yeah, allow me to share my
Yeah.
screen. Am I, is my screen being shared? No,
Not
not
yet.
yet. Okay.
Yeah. Now it has started. Yes. Now your screen is seen. You can go to full screen now.
Uh,
Yes. Full screen. Good to
okay.
go. Yeah.
Okay. So, Assalamu alaikum and a very good afternoon to you all. Thank you, Dr. Javed, for a very nice introduction. Actually, I'm overwhelmed and I'm quite honored to be with you guys to discuss about that very important and burning topic, that peripheral neuropathy. Hopefully, it will be a bilateral learning for both for you guys and for me as well. So, let me go through with it without going to the further ado. Actually, if we go through the definition, we see that what is peripheral neuropathy, often shortened to neuropathy. It is a general term describing affecting the peripheral nerves, meaning nerves beyond the brain and spinal cord. So I would go with the definition by my teacher, who is currently the president of IASP, and you, Stephen Rice. He actually defines neuropathic pain as directly caused by lesion or disease of the somatosensory system of the nervous system. So we have got mononeuropathies on the classification and the polyneuropathies. For mononeuropathies, it's a type of neuropathy that only affects a single nerve. While polyneuropathies are many nerve cells in various parts of the body which are affected without regard to the nerve through which they pass. The term peripheral neuropathy sometimes is used loosely to refer to polyneuropathies. We have got another classification, that is autonomic nerve neuropathy. These control, these are the nerves which control our functions which we are not conscious of, such as breathing and heartbeat. Damage to these nerves can be serious. We have got combination neuropathies as well, mixture of two or three or of these types of neuropathies, such as sensory or motor neuropathies. Another thing is that we come across the term mononeuritis multiplex. Occasionally termed polyneuritis multiplex is a simultaneous or sequential involvement of the individual non-contagious nerve trunks, either partially or completely. evolving over days to years and typically presenting with acute or subacute loss of the sensory and motor function, often individual nerves. So, what are the etiologies of mononeuritis multiplex? We have got some vascular causes like diabetes, polyarteritis, rheumatoid arthritis, some connective tissue disorder, systemic lupus erythematosus, some other Sjogren's syndrome, and not systemic vasculitis. Inflammatory causes include leprosy, sarcoidosis, Lyme disease, infiltrations like malignancy, amyloidosis. It may also occur after immunization or foreign serum and proteins, even after trauma. So, what is the term neuritis means? It is a general term for inflammation of a nerve or the general inflammation of the peripheral nervous systems. So, what are the clinical types of peripheral neuropathies? It can be divided on acute onset, such as GBS, porphyrias, toxics, diphtheria, malignancy, critical illness, polyneuropathies, diabetes, uremias, predominantly motor, also in GBS, diphtheria, porphyria, late CMT diseases, diabetes, predominantly sensory. We get it in leprosy, diabetes, vitamin B12 or thiamine deficiency, malignancies, uremia, Lyme disease, Sjogren's syndrome. We have got radicular, like diabetic truncal neuropathy, Lyme disease, Sjogren's syndrome, painful neuropathies. It occurs after chronic alcoholism due to nutritional deficiencies, diabetes, arsenicosis, cryoglobulinemia, Lyme disease, paraneoplastic sensory neuropathies. Uh, Pathological types include axonal degeneration, segmental demyelination, and neuronopathies. Systemic disease such as diabetes or leprosy, which I have already uttered previously, hyperglycemia induced glycation, vitamin deficiencies, some medications like chemotherapy or antibiotics, including metronidazole, fluoroquinolones, traumatic injury, ischemia, radiation therapy, excessive alcohol consumption, celiac disease, non-celiac gluten sensitivity. Also, it may present through genetically or idiopathic. It is also proven that Charcot-Marie-Tooth disease may lead to peripheral neuropathy, which has been confirmed through nerve conduction studies. Uh, HIV infection, maybe symptomatic neuropathy affects about 5% to 10% of patients infected with HIV. And leprosy is a very common cause or etiology of peripheral neuropathy. Also, it has been research and kind of an article published. I was one of the co-author of it, which also we came across some many neuropathic pain, and with neuropathic pain patients who has undergone the chikungunya diseases itself, and with this chikungunya led them to neuropathic pain in their chronic terms. For dengue patients who are also suffering for a prolonged period for with pain, joint pain, and other, they may also turn to neuropathic pain, but the research is ongoing, maybe in the Southeast Asian region. So previously, you know that in up to ICD-10, the pain was not being classified according to the International Classification of Diseases, but in ICD-11, they have introduced the pain, and they have also introduced the neuropathic pain for in their ICD or International Classification of Diseases, which included the epidemiology, health policy, and clinical use and research as well. So, if we go through that ICD of 11 for pain, and there was a task force. Like I'm working now in the neuropathic pain task force, pessimism task force. Who are working with it. So we see that there they have got a specific chronic pain variation for neuropathic pain, which included the 30.5, or we can be more specific, 30.5 Y for those neuropathic pain. So if we go through that diabetic polyneuropathy or causes like that, we can write it from the ICD-11 like HCO3.0 for diabetic polyneuropathies, like that. Actually, we can for chronic peripheral neuropathic pains we have got 30.51 is the code, and there are other codes for the other pain pain as well, besides those neuropathic pain. So, how to go with the uh, how to manage a patient actually who is suffering from diabetic peripheral neuropathies. So we see that an article from uh, I hope that you have gone through the many articles, but from the Solomon, he stated that around 50% of patients with diabetes may lead a life with diabetic peripheral neuropathy. And interestingly, glycemic control and addressing the cardiovascular is now considered an important in the overall management of the neuropathic pain. Apart from the drugs that they used to take, like SNRIs, tricyclic components, anticonvulsants, and others, but main thing is that to control diabetic peripheral neuropathy is the diabetes itself. Uh, so if we go through a bit deeper, that why it happens, actually, the pathophysiology of neuropathic pain, which is immune cells and molecules introduced, we see that there is a tissue damage, which leads to release of the interleukins, nitric oxide, bradykinin, and others, mainly tumor necrosis factor alpha from the neutrophils, macrophages, and mast cells, which actually leads to an action potential and actually initiates the pain. So we can see that why etoricoxib or COX2 inhibitors actually play a vital role over here, because they act as the ini- uh, it act as a stimulant for the TRP1 and phosphokinase and phosphokinetics. Actually, PKC and PKA, that the receptors, which are the cytokine receptors. So where there is an endothelial damage, which leads to the pain. So the key features for neuropathic pain, it is occasionally generated in response to damage to sensory nervous system. It can be spontaneous. It can be spontaneous paroxysmal. It can be evoked. So prevalence is around 7 to 10% worldwide. So what are the common complaints? Loss of sensory, loss function like numbness, anesthesia dolorosa, elevated sensory thresholds, gain of sensory functions like paresthesia, dysesthesia. It may also have hyperalgesia, allodynia, hyperpathia, or paradoxical heat sensations. So let me go through with the diagnostic approach. So just common symptoms: muscle weakness, cramps, muscle twitching, loss of muscle and bones, changes in skin, hair or nails, color, numbness, loss of sensation, loss of balance, emotional disturbances, disruptions, loss of pain, inability to sweat properly, loss of bladder control, dizziness, lightheadedness, diarrhea, constipation, trouble eating or swallowing, life-threatening symptoms such as difficulty breathing or irregular heart breathing. During neurological examination, distal sensory motor and sensory loss, proximal weakness, maybe in such inflammatory neuropathies or GBS, focal sensory disturbance or weakness, mononeuropathies, ankle jerk reflex, absent in peripheral neuropathies. Uh, to confirm, we have got a tuning fork heart, which must be 128 hertz tuning fork test, which will give us the clue that through decreased sensation to vibration in large fiber neuropathies, nylon monofilament, decreased sensation of light touch. So these are the tools that we need actually, that 128 hertz tuning fork, monofilament, to do the bedside examination for neuropathic pain. Uh, some neuropathies are purely motor, like multifocal motor neuropathies with conduction block or sensory, subacute sensory neuropathies. Small fiber neuropathies manifest with dysautonomia, such as sweating, pupillary, cardiovascular, gastrointestinal, and micturition disturbances. These features may also be found in uh, GBSs. So if we go through the diagnostic algorithm for small fiber neuropathy, we can first assume from the history that it may be a possible neuropathies. From clinical examination, probable neuropathies, and nerve conduction is steady. If it is normal, then it can be either clinically confirmed small fiber neuropathies, or if it is abnormal, then clinically confirmed uh, that may be large fiber neuropathies. So if it is asked that what is the confirmatory test, the confirmatory test actually is the skin biopsy, which is the minor outpatient procedure. It is actually image analysis rules and age gender matched. For detecting the somatosensory system, damage sensitivity is around 84% and specificity is around 86 percentile. Strong recommended in diagnosis of small fiber neuropathy, particularly when nerve conduction studies are normal. So uh, there are also some needle electromyography. We can do somatosensory evoked potentials, examination of the CSF, QSTs, molecular genetics, autonomic function studies for the peripheral neuropathies. Apart from those, we can do the basic laboratory investigations, for example, the complete blood count, along with the erythrocyte sedimentation rate, fasting blood sugar, serum electrolytes, serum proteins, serum creatinine, liver function tests, which may give us some clues, maybe some cryoglobulins, porphyrins in the urine, rheumatic factors, and the serology for Lyme disease to find out the etiologies. So, what about the QST? I don't know whether it takes place in India. I think maybe most of the modern world they do it in the bedside. It's quite high sensitivity for small fiber neuropathy, even though when there is normal NCS or EMGs. So, uh, but unfortunately, it cannot differentiate that sensory loss from the sensory neuropathies. There is another bedside test is the electromyography, which is actually quite effective to diagnose the diabetic neuropathies. But the difference between that electromyography and nerve NCV is that electromyography is quite a bit invasive, which is quite painful, whereas we can go do the nerve conduction study, which is kind of painless stimulation. We have got some electrophysiological tests as well. That significant fraction of chronic diabetes with painful distal symmetrical or primary sensory polyneuropathies. But primarily in sensory modalities, it is inappropriate to use the common electrophysiological tests. Uh, what about the QST versus others? Uh, Test performance characteristics do not permit discrimination among subjects simulating sensory loss, subjects with normal responses, and subjects with peripheral neuropathies. So now, what about the medications that we have with us? We have got the antidepressants, uh, SNRIs, anti-epileptics like GABA, which is commonly used like gabapentin, pregabalins, opioids and opiate medication in higher doses, obviously like buprenorphine, morphine, methadones, fentanyls. Others, paracetamols, NSAIDs, cannabinoids, even topical capsaicin and lidocaines are also used. Capsaicin is actually the game changer, the 8% patch, which was introduced by David Julius and Adam Pataputian in the year 2021. For this, actually, they won the Nobel Prize, from where we usually say that from chilies start chilling. Initially, I don't know whether it is available in India or not. In Bangladesh, it is not available, but quite available in the Western world and in the Southeast Asian. Initially, it gives a burning sensation, but in the long term, it actually prevents the pain, especially the neuropathic pain. This is a picture. Well, I was receiving the award in the last year through IASP with the Nobel laureates who own the actually who invented the capsaicin cream, Adam Pataputian and David Julius. So actually, there is also an effectiveness of intravenous ketamine and lidocaine on peripheral neuropathic pain. Ketamine showed that significant analgesic effect in case of neuropathic pain also. So it can be also introduced. And actually, there is a confusion that whether we should prescribe vitamin B for treating peripheral neuropathies or not, whether it's kind of placebo or not. But there are only limited data actually in randomized trials testing the efficacy of vitamin B for treating peripheral neuropathies. But we commonly actually prescribe it. Strict gluten-free diet is an effective treatment when neuropathy is caused by gluten sensitivity, with or without the presence of digestive symptoms or intestinal injuries. Counseling is a very big part for our pain management, not only for the peripheral neuropathies or neuropathic pain. So actually for the psychological interventions of chronic, it's a kind of counseling that we usually go through. So what about the acupuncture for symptomatic treatments of diabetic peripheral neuropathy? Uh, it was previously believed that acupuncture plays a vital role, but eventually they have withdrawn the publication that acupuncture is actually beneficial for peripheral neuropathies or not. There is a quite a bit confusion. Herbal medicinal products. I don't know that whether it is quite available in India or not, but in the Southeast Asian, especially in Thailand, they have got the traditional medicine. In Bangladesh, previously they used to have a lot of herbal medicine, but as the day progresses, it is not being used that much. But whether in nutmeg or St. John's wort, it has got some evidence that herbal medicine may work. Uh, Another article is going to be published. Actually, I was one of the researcher and the co-author of this article, which has been accepted in the neuromodulation, that the effects of transcranial direct current stimulation and pain intensity with chronic intractable peripheral neuropathies, it has got a very vital role as well for patients who's actually through intervention or through drugs or maybe through injectables, medication, or maybe through CBDs and others, we are unable to treat them. We can go for this TDCS as a savior options apart from the spinal cord stimulation. So the newer guideline has been already published, and I would request you to. I was part of it, the newer guideline which has been published in recently, and I think that if you have any further interest, please go through the Lancet Neurology, and you can get the latest guideline as well. So of the management of the neuropathic pain. So that's all about my presentation or my talk, whatever it is. I think a bit of knowledge sharing, and hopefully it was kind of beneficial for you. Thank you. Uh, Dr.
Thank you very much. It was a wonderful presentation, Dr. Zunaid. I'm sure all of them have got sensitized about management with peripheral neuropathy and the different aspects. Now, I'd like to request the participants to ask any questions if they have, or put it in the chat box as well. So one by one, you can ask. I think Dr. Sunil was having a question.
Yes, please.
No, no, sir. No, sir.
Okay.
Uh,
So if anybody have any questions, please feel free to put it in the chat box, or you can unmute yourself and you can ask. We have Dr. Junaid with us, and he is one of the best in this particular topics. Uh, Happy to know that you are part of framing the guidelines as well.
yeah, thank you.
So yeah,
Yeah,
very nice.
yeah. It is the first time that a guideline is being published and
Yeah,
official. Yeah. So I think if anyone is interested to know further about the neuropathic pain, they can go through with it. The Lancet Neurology.
yeah.
Okay.
Okay, so we have the first question from Dr.
Yeah.
Smita, who's asking how long can we use capsaicin patch for peripheral neuropathy?
Actually, there is no specific time for it, but usually maybe a week or two is a good option to use it. Initially, there will be much burning sensation. Later on, they get used to with it. So maybe a week or two will give them a lot relief.
Okay.
But make sure it's the 8% capsaicin.
Hmm. Yes, very true. I don't know if 8% is available in our country. It's available freely in your country?
No,
8.
no, no. It's not available in Bangladesh as well. But
Okay.
in a modern, actually, in the European countries and also in the Southeast Asia, it is being used. And that's why they won the Nobel Prize in the year 2021.
Yeah, yeah, very true.
Yeah.
Hope that answers your question, Dr. Smita. So, anybody else, if you have any other question, please feel free to ask. Dr.
Yes.
Junaid is
Yeah.
there with us.
Okay. Can I add to that
Yeah.
capsaicin? Actually, before prescribing, you need to give some instructions for the capsaicin cream. Is that the patient should be the area should be cleaned, and at at the same time it should be dried before applying, and it's better to apply in the night. And if you are prescribing for twice, make sure that the patient is not going to the sun, or maybe going to out to the heat or humid weather, because it's going to burn more in the initial days,
I think
because
that's a very
it's coming from the chilies, right? Chilies to chilling.
red, red chilies. So, Dr. Zunaid, I think
Yeah.
one of the questions which we've had over here is that a lot of patients you would have seen having radicular pain, low
Yes.
back pain with sciatica, or radicular pain, and few people will have diabetic neuropathy as well, or any
Yes.
other form of neuropathy. So, how do you differentiate between a radicular pain and a neuropathy pain?
Actually, the thing is that, as I have stated that for the diabetic neuropathies, you need to go through with the diagnosis through clinical examination and a good history, which will say whether it is probable neuropathics or possible. And then we have got the confirmatory test, like whether it is due to diabetic neuropathies or not. And for the radicular pain, you will have definitely some clues through the images that we do actually, that is there any nerve trapping over there, or whether there is any uh, disc prolapse which is actually making the nerve inflamed. So you will get actually the clue from the history, the clinical examination that we do for the radicular pains, and also the images that we get for the radicular pain, whether there is entrapment of nerves or any inflammation. And for the diabetic peripheral neuropathy, the patient will give you a long history of diabetes and maybe uncontrolled diabetes, and the pain will be gradual, and the pain will go through the gradually, and you can do that the bedside test that we do, the QSTs and EMGs and others, NCS. You will get a clue. If even though if you are not confirmed, you can do the maybe that biopsies that we do
Yeah,
to
wonderful.
diagnose the small fiber neuropathies. For
Yes,
that,
yes.
yeah.
Good. Okay. Um, One more question is that, what would be the role of uh, basically investigations like an MRI or
Yeah.
any other advanced imaging in case of peripheral neuropathy?
Actually, the guideline states that it has got very little role or no role that we actually go prescribe for the actually it's a common prescription or common requirements for the pain physician, especially the early ones for the peripheral neuropathies, that we prescribe the images or asked to do the images. But it has got no role for the peripheral neuropathies, unless and until you think that there is nerve entrapment, or you need to do the interventions, or there is radiculopathies. I think there is no role of it.
Yeah. And if you look at the investigations as such, so do you think anybody coming with a neuropathy should be screened for the vitamin B levels, the HbA1cs, the thyroid levels, etc.?
Actually, yeah, if you need to find out, if you don't get a history, like many of the patients in our practicals, we see that they are diagnosed with diabetes for the very first time when they come to us. So I
Yeah.
think that to get the etiologies, and we know that the main treatment for diabetic neuropathies is that control of the diabetes itself. It relieves the pain around 50%. So as I've shown previously, so to get to get to the diagnosis, to get to the appropriate treatment, we need to go through those baseline investigations.
Very true. Okay. And if you look at the management per se, basically,
Mm.
uh, how do you choose between gabapentinoid or an antidepressant? Which do you think, for the candidates to understand, to make a choice, which do you think would be a better choice for a peripheral
Eh,
neuro?
Yeah, it's a very good question. Actually, I don't know who did it, but I think that it's a very good question and very practical question. Actually, it is actually individualized. When you are going to prescribe, it is
Yeah.
individualized because we know that antidepressants act on both the sodium and calcium channels, but the gabapentinoids acts on only sodium channels. Sorry,
Yes.
only in the calcium channels. So
Gotcha.
the thing is, whenever you need to first identify the intensity of pain, and then we know that there are some side effects for of the gabapentinoids. So we need to consider those as well, whether the patient is young or the patient is aged, whether he has some or she has some machinery works, or whether he needs to go early in the morning. Actually, those are the things, and we need to also exclude the cardiac abnormalities before prescribing the
Yeah,
antidepressants or SNRIs.
very true.
Yeah,
I think that would have cleared the doubt which most of them had. So, if you look at the interventional pain procedures which are there, right? Be
yeah.
it nerve blocks or the advanced intervention like spinal cord stimulation, what do you think is the role of these interventional pain procedures in peripheral neuropathy?
Actually, in peripheral neuropathy, if if it is actually combined of other uh,
Yeah.
conditions like facet joint arthropathies or maybe radiculopathies, then there might be a role of the intervention. But if it is only solely about peripheral neuropathies, actually we don't go first for the interventions. We must
Yes.
try first for the medications and maybe some therapies like CBDs and QSTs and
Yeah.
others.
I think that's a very important take-home point from today's webinar, is that many of the time you get patients in the OPD who come with these severe peripheral neuropathies, and many of the time people tend to think that maybe interventions is the first two option,
No, no, no.
where when it's totally the opposite.
Yeah,
You have
actually,
to
yeah.
try with the medications, you have to try with the other things. Now, when I'm talking about these things, Dr. Zunaid, what do you think is the importance of lifestyle modifications over here? Do you think that also plays a role in peripheral neuropathy? Diet,
Obviously, if you go through
lifestyle.
with the first three or four most common causes,
Yeah,
like you will find out that diabetes, uncontrolled diabetes, then chronic alcoholisms, and others that actually related gluteins, high gluteins diet, obesities. So
yeah,
these are the things actually that play a vital role in the peripheral neuropathies. So actually, if you can overcome those things, you can control peripheral neuropathies nearly about 50% or more. So
mm,
that is the prime thing that we should consider uh, as a treatment also, not the lifestyle modification that is not okay, something that we can do it or not. It's a kind of a part of your treatment so that we can manage it.
very true. Now, coming to the other important aspect is cancer patients.
Yeah,
So, chemotherapy-induced neuropathy is another one thing, right? Which
yeah.
is very rampant. So, how do you think we should approach this and treat this?
Yeah, it's a very good question. I think that uh, if you go through the cancer patients and the cancer pain, you will find that the most of the patients are actually suffering from of pain before they have been diagnosed as a cancer or maybe due on chemotherapies. So we should first exclude that other causes which was actually pre-existing within the patient, and then if we actually are confirmed that it is due to chemo-induced neuropathic pain, then we should think about multiple drugs at the same time because they have got both pains. One is due to the cancer itself, another
Yeah,
is the chemo-induced neuropathic pain. So we must consider both the pains simultaneously and prescribe multiple drugs to avoid a single drug toxicities. Even we can go with some, as I have stated, like ketamines or lidocaine infusions, which are actually quite helpful for them as well.
agreed. Okay, so another intriguing question, which is there in many people's mind, is the role of regenerative therapy over here. Is there a role, do you think, can PRP, stem cells, or prolotherapy or ozone play any kind of a role in case of neuropathies?
Actually, not in case of peripheral neuropathies, because uh, as I've stated earlier, that there for intervention there is very little or no role of interventions in case of the treatment of peripheral neuropathies. If you go through the guideline, you will find it out. But actually, if there is coexisting some diseases that may need, or maybe some uh, new disease or new etiology of pain is accompanied with the peripheral neuropathies, which might need interventions, then we can go with that.
Very true. Okay, so I think a well-rounded up thing, even the questions as well, you've answered really well, Dr. Zunaid. So finally, before we conclude the session, any final points or any final tips you want to tell to our audience?
Yeah. First, we must listen to the history in details. It gives us a clue.
Yeah,
Then, if we are thinking that the patient is having a probable neuropathic pain, we must go with the clinical examination, which may guide us to the possibilities of neuropathic pain. We can do the bedside examination. If you think that the patient is having a neuropathic pain, we can go with the confirmation, and at the same time, we can do the basic investigations to find out the etiology. We can go with the treatment, but never with the interventions at the very first time. And obviously, we must keep in mind that counseling is very important for those neuropathic pain patients, because we need to change their lifestyle as well.
yeah,
So, lifestyle modification is very important in peripheral neuropathies as well. So, we have got lots of options for the treatment. We have got the best of drugs available for the treatment, but we should use it rationally. Maybe, for example, if we are going to prescribe the gabapentinoids, we must state the side effects to the patients, so that whenever they are in need, they can uh, change it to a different one, like the side effects, especially the young male patients.
sure, sure. I think that is food for thought. And thank you very much, Dr. Zunaid, for being a wonderful resource person for today's topic.
Always my pleasure.
And we are very thankful from our Algos Academy of Medicine to have you as a faculty on this particular topic in itself, wherein we have the person who helped formulate the guidelines itself for peripheral neuropathy. And we look forward to future collaborations as well with you.
Uh,
And I'd
sure.
like to thank our participants for joining our webinar. And soon this is all recorded, so we'll be uploading it soon in our channel as well. And I'll be sharing the link to Dr. Zunaid as well. Thank you very much, Dr. Zunaid.
Yeah. Yeah. Thank you very much for inviting me, and hope to meet you again. Thank you very much.
Thank
Yeah.
you very much.
Thank you.
Okay, so this was from today a very different topic, peripheral neuropathy, but still a very common topic which has been really addressed well by Dr. Zunaid, our resource person. I thank you all for joining a webinar, and soon we will be announcing our next webinar and what topic it will be in. So keep looking at pages for the further updates. Thank you all. Good night.